And the one recommendation that they have is that one should never use the quick sofa in isolation when compared to mews, meows, and proper sofa scores. Okay. Now, moving on, sources of maternal sepsis. Besides all the usual sources of sepsis that we can think of in the non-pregnant patient, we have quite a few that are specific to the pregnant population. We start off with the renal tract, urinary tract infections, pyelonephritis, and complications of hydronephrosis. Remember that the gravid uterus is going to cause pressure on the ureters as they pass behind the uterus. A degree of hydronephrosis will happen, which predisposes to urinary tract infections and pyelonephritis. Respiratory, the growing uterus, abdominal pressure, which we talked about last time, will cause a degree of basal collapse because of loss of functional residual capacity, will make you more prone to different types of pneumonias. Aspiration pneumonia, because of indeed the increased risk of reflux, bacterial, viral, and even fungal pneumonias. Mostly bacterial, both the typical and the atypical bugs, as well as viral pneumonias, H1N1. Indeed, the 2009 H1N1 epidemic and its particular effect on pregnant women is how we made groundbreaking discoveries on the superiority of proning to high-frequency oscillation, the use of ECMO in these patients. So unfortunately, we do owe a lot to respiratory dysfunction in the pregnant population as to how we manage acute respiratory distress syndrome nowadays. More septic sources, the uterus itself, chorioamnionitis in all its shapes and forms, retained products of conception after normal delivery, be it a septic abortion or some form of adherent placenta like placenta creta or placenta percreta. Endometritis and myometritis, inflammations of the uterine lining or the uterine muscle, and or an abscess in the uterus. Apart from uterine causes, we have the non-obstetric abdominal causes like a ruptured appendix or acute appendicitis. Indeed, there is an increased risk of appendicitis during pregnancy. I don't remember it being a very high value. I believe it's in the 10 to 15%, the increased likelihood of getting appendiceal problems. Bowel infarction, gallbladder problems, and necrotizing pancreatitis, as with or even non-parturient patients. Oh, sorry, apologies. Yes. Wound, sepsis, be it an episiotomy, infection, a non-diagnosed perineal laceration, or some form of fasciitis from a cesarean wound. Last but not least, we have the broad miscellaneous box where we throw in all the infections that are non-organ specific, but are associated with the peripartum period. Either some form of pelvic vein or thrombophlebitis problem, a blocked alveolar duct during or right after lactation, and also if a neuraxial intervention was carried out, like a spinal or an epidural, this is a potential source of infection. So as you can see, the list of sources of maternal sepsis is quite significant. The pregnant patient, as we've already talked about, has already quite a few risk factors for maternal sepsis. Cesarean section remains the single most important risk factor. Just as a brief aside, the amniotic fluid, we might be given the impression that amniotic fluid is some form of crystal clear, pure fluid that the baby just bathes in. In reality, it is a mixture of sloughed skin, fetal urine, fecal matter, sloughed skin, and amnion. So it is literally the equivalent of sludge or dirty water. So one can appreciate that the amniotic fluid is in itself a haven of bacteria and the potential risk for sepsis. Home births in unhygienic conditions, poor nutrition, primates are more susceptible to infection, as are multiple pregnancies, multiple examinations in labor, which is in fact why at least our trust has a limit as to how frequently women are examined, and the interval of time is pre-established, and an examination before this has to be justified. Prolonged labor and prolonged rupture of membranes, obesity, obstetric maneuvers such as forceps delivery, and internal devices. All of these are risk factors for maternal sepsis. Common bugs, which are culprits for maternal infection. You have the usual, the gram-negatives like E. coli and Serratia. The streptococcal group, especially the group A streps, particularly in the case of prolonged membrane rupture, which is why it is heavily recommended that prolonged membrane rupture is covered with some form of beta-lactam antibiotic, and the Bacteroides subgroup. There are specific bugs that tend to thrive in the amnion and in cases of chorioamnionitis, such as chlamydia and ureaplasma. Now, on to the main event, the management of maternal sepsis. So, the key recommendations from the last maternal death reports in the United Kingdom is that all hospitals adopt a modified early obstetric warning score, a MEOWS for short, that is used to aid timely recognition, the treatment, and the referral of women who are developing a critical condition. So that is the first recommendation. A modified early obstetric warning score would look something like this, where aside from the usual MEWS parameters, respiratory rate, saturation, temperature, etc., it takes into account other conditions that are typical of labor, such as discharge, proteinuria, pain excluding labor, and also gives different scorings because of the physiological changes we have already talked about. So, the adoption of a modified early obstetric warning score for all admitted obstetric patients is a key determining factor on picking up sepsis early and treating it early. The second general principle is that a few studies have been actually carried out for a variety of ethical and non-ethical reasons on the treatment of maternal sepsis. So a lot of what we talk about when it comes to management is an extrapolation of the Surviving Sepsis campaign, which, as you all know, is a worldwide move, heavily contributed to by our European Intensive Care Society, where every few years the management of sepsis worldwide is brought under scrutiny. So, yes, we do not have studies specific to the pregnant population. However, it is not unreasonable to extrapolate the findings we have for the non-pregnant population and apply them to the peripartum population. Okay? So, general management, in the context of sepsis, we aim for a mean arterial pressure of more than 65 millimeters of mercury. This guarantees a perfusion pressure of both the maternal and the fetal microcirculation. Which brings me to my very first a very important point. It is important to differentiate sepsis from the hypertensive disorders of pregnancy. Remember that the management of the preeclamptic and the eclamptic patient, which is something we will talk about in the next lecture in this series, is very different from that of the septic patient. So care must be taken to be relatively confident in the diagnosis of what is going on, because the management of sepsis, which we will see now, is very different from what we would do for a pre-eclamptic or indeed an eclamptic patient. Okay, so continuing on management, we aim, as we said, for a MAP of above mean arterial pressure of above 65, a urine output of more than 0.5 ml per kilo per hour. If the patient is hypotensive, as we always do, fluid resuscitation should be immediately started with fluid challenges of 20 to 30 ml per kilo. As we know, significant volumes might be required in septic shock. I mean, I could spend the whole day talking about fluid responsiveness in sepsis and the appropriateness of fluids in the context of septic shock. But all I will say for the specifics of this lecture is this: that the pregnant patient is particularly susceptible to large volumes of fluids. This is because of the lung capillaries, as we talked about last time. They tend to be a little bit leakier than the non-pregnant patient. There might be a degree of myocardial suppression because of sepsis, and also the strain and the hyperdynamic circulation we see in pregnancy. So an excess amount of fluids might not be as easily handled by the pregnant patient as by the non-pregnant patient. So here I add a line that consideration for thermodilution techniques like PICO, LITCO, PROACT devices for cardiac output monitoring should be considered. And of course, echo is ever our friend here, and it is a safe, non-invasive way of assessing fluid response and fluid dynamics in the pregnant patient. Okay, continuing on management, when it comes to vasoactive agents, noradrenaline is the first-line agent, as indeed it is for all septic patients. The second-line agent will depend on the specific context. Most patients will get as second agent vasopressin. If you're suspecting some form of anaphylactic response, you might consider adrenaline with caution. Dobutamine is a significantly good inodilator, so it will increase contractility. Phenylephrine, proven to be quite a safe, albeit I always consider it the weak, distant cousin of noradrenaline, because we're essentially targeting the same receptors, but noradrenaline is a naturally occurring substance, whereas phenylephrine has been produced in a lab. But yes, it can be considered as first-line agent in milder forms of sepsis. My second point, low-dose hydrocortisone may be used in adult septic shock when hypotension remains poorly responsive, and you see that your vasopressors are rising. The adrenal trial back in 2017, 2018, I think, which had shown that low-dose corticosteroids of 50 milligrams per hourly in the adult population decreases mortality and increases response to vasoactive agents. In later stages of pregnancy, the use of steroids is safe. It's earlier on when they would be considered harmful. Insulin, very important for the control of hyperglycemia in patients with severe sepsis. An infusion regime based on the NICE sugar trial, which was based on the earlier Van Leeuwen trials, aims to keep the glucose in a range between 6 to 10, 8 being perfect gold standard. Coagulopathy is common in maternal septic shock, so unless there is a significant contraindication, anticoagulation can be started in these patients, prophylactic anticoagulation. And as always, I should actually have added the last three points as a slide on their own in bold flashing letters: multimodal organ support, source control, and daily flip fast hugs in bed. What do I mean by this? So The fast hugs concept was a move created by Jean-Louis Vincent in the 90s, where he tried to create a model on how to be able to carry out daily housekeeping in high dependency or critically ill patients. And he started with the fast hugs model. Fast hugs being a mnemonic standing for important things to look out for in each and every patient in his ICU or HDU. Locally, we've modified it and we've added a flip and a bed at the end, and they would look something like this. So the flip bit would remind me, when taking care of these patients, to liaise with the firm, in this case, the obstetricians and or the pediatricians, to look at the lab results, to make sure that I have the latest imaging and to ask myself whether I need to consider more imaging and whether I need to consider physiotherapy. The FAST stands for creating a fluids and a feeding plan, A for analgesia and or anesthesia, S is for intubated patients, whether they need a sedation break and whether I should consider putting them on a spontaneous mode of ventilation, a spontaneous breathing trial. T, to consider thromboprophylaxis. And now we move to the hugs. H for head up, nursing the patients in a 30-degree position, moving away from the recumbent flat position we used to nurse patients in the past. U for ulcer prophylaxis. G for glucose control, which we've talked about. S, skin and lines. Any old lines that need replacing, are they a potential source for sepsis? A cannula or a Venflon that hasn't been used for an amount of time. In bed, I is instructions and N is the nursing chart and an appropriate checklist. In this case, this would be the modified early obstetric warning score, which we've talked about already. And bed is bowel care, reviewing the drug chart, and very important to explain my targets to the staff, making sure that my plan is clear and transmissible to the rest of the caring team. Okay, so this is just something really and truly applies for every patient, be it pregnant or not, irrespective of whether it's a surgical or a medical high dependency intensive care setting. This is a short mnemonic to remind ourselves of the things that we should not miss when reviewing these patients. Okay, moving on. Continuing on our management, antibiotics, the mainstay of treatment of infection. So, as we all know from the Surviving Sepsis campaign, intravenous antibiotics should be started as early as possible, always within the golden hour, the first hour of recognizing severe sepsis. And remember, severe sepsis is sepsis, which is a dysregulated response to infection, severe being because there is organ dysfunction. If they're hypotensive, it becomes septic shock. I'm sure you are well aware of this. It is recommended that a broad spectrum approach be adopted using one or more agents depending on the local environment, the local biome, and penetration to the presumed source. And obviously, having a de-escalation plan always at the back of your mind. Okay? Appropriate cultures should be obtained immediately, but this should not delay the starting of antibiotic therapy. At least 2 sets of blood cultures are advised, one of them being a fresh stab. Other sites to consider, apart from the usual ones, would be swabs from the throat, the vagina, and the baby, if the infection is suspected to have come from labor or during delivery, a midstream urine sample, and other relevant samples from breast milk, stool, sputum, as indicated. Something about antibiotics. The usual regimen we tend to use is ampicillin and or cephalosporin like ceftriaxone, gentamicin, and clindamycin. Gentamicin for its gram-negative cover, and clinda for its toxin suppressant effect. These would be our first-line empirical therapy. Meropenem and vancomycin would be our backup, second tier, or indeed tazocin, something like piperacillin, tazobactam. All these have been found to be relatively safe in the peripartum period, as indeed have macrolides and nitrofurantoin as well. Unfortunately, some antibiotics are either contraindicated or have to be used with care. Vancomycin is safe in pregnancy, but as we all know, it tends to be very nephrotoxic. Other agents are detrimental to the baby. Things like sulfonamides, tetracyclines, chloramphenicol, other aminoglycosides, apart from, gentamicin, and some, indeed most of the antifungals. The only one having found to have stood the test of time and remain safe is amphotericin. So care must be taken in the choice of antibiotics and its use. Okay, something about fever, because despite having spent already 40 minutes talking about infection, we haven't talked about the single usual marker of infection. Do you have a temperature? This is because, like most things in pregnancy, even fever tends to be a false friend. In labor, maternal pyrexia is associated with many things: prolonged labor itself, the ambient temperature, epidural analgesia, all these tend to push up your temperature. Maternal tachycardia, the tachycardia that accompanies a fever, may be the result of dehydration, labor itself, or some sinister cardiorespiratory pathology. However, something very important to consider is something that we indeed have already mentioned, that chorioamnionitis is associated with increased neonatal morbidity and mortality. And if suspected, this should not delay the administration of antibiotics, irrespective of the temperature of the patient. So I did quite a lot of research to try and see whether anything had changed from a few years back when I was looking at the evidence. And indeed, the major consensus I find is that there is no real consensus. The one thing that I have noticed is that temperature is taken to be, the cutoff is a little bit higher than the non-pregnant population, has to be taken over multiple readings, and it is important to always be consistent as to where you're measuring temperature. Underarm temperature can be a little bit elevated because of the proximity to the breast tissue. It can be engorged, producing milk, and can be quite warm itself. So nasopharyngeal or buccal temperature is what we usually go for. But more about this, I have a separate lecture on the care of the parturient patient during labor. But so sorry for that. The key take-home message is that even fever is unreliable. Okay. Approaching the end of the lecture, I've collected a little bit. This data is easily available online, but I have summarized the European Society of Intensive Care Medicine, the Society of Critical Care Medicine, and the Surviving Sepsis Campaign evidence in some slides. It is really a summary of what we've already discussed. They talk about the suggestion that patients with suspected sepsis should be at least admitted, if not to an ICU, to a high monitoring area within the first 6 hours of diagnosis. They talk about the tools for screening, something we've already hinted at, that any single tool should not be used in isolation, and when using scoring systems, the MEOWS, the Modified Early Obstetric Warning Score, is the one with the best evidence for sensitivity and specificity to picking up the septic parturient, and also the importance of measuring blood lactate. Initial resuscitation, they talk about the treatment having to be prompt. Indeed, it is the one which is labeled as best practice. And then they talk about how to guide your resuscitation, guided by parameters like capillary refill time, urine output, the dynamic markers of fluid resuscitation. So when we talk of dynamic markers, things that change. Is your blood pressure improving with your fluid bolus? Is your heart rate dropping? If you have an arterial line in, is the shape of the arterial line improving? Is your pulse pressure going down? So dynamic markers being superior to static ones. Okay, we talked about the target temperature, which is recommended at a mean or a MAP of 65 or higher. When talking of infection, it is a very busy slide. There is nothing to talk about here. It just talks about early evaluation, rapid assessment of the likelihood of infection, early treatment with antibiotics. If you suspect MRSA, methicillin-resistant Staph aureus, you should be treating for that early on. And the empirical use of antibiotics, but the avoidance of empirical antifungals. Those have to be started with a high degree of suspicion and after having cultured something. Okay. Antimicrobials need to be then tailored to the bug that has been cultured. And obviously, the importance of source control. Hemodynamic management, things we've already talked about, the addition of steroids, if not contraindicated, noradrenaline or norepinephrine being the first line agent above all others, and the care of these patients in a monitored area. Additional therapies, novel therapies like vitamin C have not stood the test of time. Indeed, they are not recommended. The same for polymyxin B. Corticosteroids have indeed been proven to improve mortality. They talk about pharmacological agents to prevent venous thromboembolism, things like Clexane. They talk about the use of bicarbonate if the patient is suffering a kidney injury. In the attempt to try and avoid the use of renal replacement therapy, CRRT, one would be well advised to try to use bicarbonate therapy to try and protect an injured kidney. And with regards to ventilation, these are things that I will talk about in another slide when I talk about ventilatory strategies for these patients if they end up intubated. Okay. Again, long-term outcomes. This highlights the importance of discussion with patient and families as to the risks of sepsis, communicating the risks of therapies and the limitations in these therapies, especially in the pregnant population, and also the importance of assessing these patients even after they have left hospital for regular physical, cognitive, as well as emotional assessment after hospital discharge. Summary, the pregnant patient is particularly vulnerable to sepsis, as we said, due to their borderline immune function, so one must be constantly vigilant, suspecting sepsis at every time. It is challenging to assess septic parameters owing to the many changes the patient goes through, so do not fall for red herrings. There are numerous other septic sources to consider, so appropriate surveillance, many risk factors for sepsis in this subgroup of the population, and we've talked about how to treat them, adapting your parameters to the established early warning scores, and treat based on extrapolations of the surviving sepsis campaign recommendations. Thank you very much.
Thank you very much, JP. That was an interesting lecture. If there are any questions, you can either type it in the chat box or raise your hand so that we allow you to unmute yourself so you can ask any questions. So you can either type it or raise your hand.
I am all eyes and ears. Any question you might have, I will be delighted to try to answer. It would be interesting to know also as to what are, if anyone wants to make comments rather than a question, the the current practices in obstetric anesthesia, obstetric medicine at Hope Exchange, and given the rapid expansions you're making in that area, whether there are any areas which you think might need more work. In particular, today we've talked about the septic patient and how you think practice can improve at Hope Exchange in this regard. So I'll be happy to hear your thoughts and opinions as well.
Okay, so Dr. Yani, the obstetrician in charge, he's here. So maybe Dr. Yani, if there's anything you want to add on for JP.
Hello?
Hi,
Yes, I hope I can be heard.
I can hear you loud and clear.
Yes, thank you so much for the lecture. I think it's an insightful one. Um, Unfortunately, we haven't had to deal with so much cases of sepsis at Hope Exchange because I think most of the time we give a lot of antibiotic prophylaxis, especially for our patient who present with prolonged PROM, and then those who present with prolonged labor, we try and cover them up with antibiotics.
I wouldn't say unfortunately, then I think you're doing a great job and you're doing things right if you haven't seen it much.
Yes. The challenge we currently have is with our critically ill patients, those who need ICU care, like those with preeclampsia complicated by pulmonary edema, and yes, those who present with sudden cardiorespiratory collapse, like cases that we suspect pulmonary embolism, and those kind of staff who need ICU care. They are the ones that sometimes we have a lot of challenge, especially trying to make the right diagnosis and then
Yes.
The right kind of treatment to give them.
And you are absolutely right in saying that, because they also pose a challenge when it comes to diagnosing them, because the instability of these patients tends to preclude any, say, travel to theater or easy diagnosis with ultrasonography. The pulmonary edema itself can make imaging very difficult. So yes, and the preeclamptic patient can behave particularly like the early septic patient. The only difference is that this patient is hypertensive. So yes, they are indeed a challenge. Okay, there is a question in the chat. Please, may I know the role of the anesthetist in maternal sepsis management? Oh, music to my ears. So the role of the anesthetist in this case is unique because you are in the privileged position of being the one who is going to help the obstetric team in the diagnosis of these patients, because anesthesia exposes us to sepsis in various nature and varying degrees, being patients presenting in a septic state to theater or managing them in an ICU. You will be the one who will be lining the patient up, whether the patient needs an arterial line, a central line. You will be guiding fluid resuscitation as well, or more often than not. The management of these patients tends to be heavily reliant on the anesthetist and our role in fluid management. Indeed, my old boss used to tell me that the anesthetist is the guy who puts a drip in and puts a tube in. But indeed, it is these drips and tubes that are going to be so fundamental, especially in the early stages of septic shock, where you're presented with a shutdown patient who needs urgent vascular access, judicious use of fluids, timed antibiotics given via a dedicated line, and also the monitoring of advanced parameters like dynamic responses to fluid challenges, and the monitoring of these critically ill patients. So yes, the role of the anesthetist is vital if part of a multidisciplinary team. And indeed, what we do on our labor ward is that there are twice daily ward rounds, which the duty anesthetist or the consultant anesthetist joins. And we have an overview management of the patients on the unit, and any major deteriorating patient is reviewed by the anesthetist with the obstetrician, and is then either referred to us in ICU or managed upstairs in our maternal HDU if they do not need ventilatory or more than 2 organ supports. We tend to keep the patients upstairs, the ones who are stable on preeclamptic treatment, which I will talk about in the next lecture, and or are single organ, so hypotension requiring fluids, or a kidney injury, or some form of fetal dysfunction. Just one organ. 2 or more, or cardiorespiratory, you come down to ICU. I hope that answers your question, Issa.
Okay, so I think that should answer his question. Okay, he says thank you. So any other questions, contributions? For me, I think my take home from this lecture is that the obstetric department will have to start using the meals checklist. So Dr. Yani, if you can do a training for the team on the use of the modified early obstetric warning system, so that
I have some material on the monitoring of these patients separately. It can be a separate lecture. The modified early obstetric warning scores are available online. The Royal College of Obstetricians and Anesthetists have made it available worldwide. So it is a standard warning score. As to its implementation, I have some material which that will mean yet another lecture with me, I'm afraid. But I'll be very happy to present how, at least locally, how we use it and how we get it to help us in the early detection of these patients.
Okay, I think that would also be helpful. And also that CT scans are not contraindicated in especially late pregnancies, because sometimes we are always hesitant because of the risk.
And also that hesitation is worldwide. It is a justifiable fear in the first trimester, but once that is passed and you have a hypoperfused fetal-placental unit because of sepsis, because of an undiagnosed abdominal problem, and nowadays the CT scans, which are reducing the dose of X-rays given per CT, it almost becomes unjustifiable not to do the CT scan, especially if an abdominal pathology is suspected and you are going to expose the patient to some form of surgery with the risk of premature labor that accompanies anesthesia and surgery prior to delivery. So I would say it's a double-edged sword. You might also be saying, listen, you're sort of up against the wall, hard to justify not to scan this patient, especially in the late stages of pregnancy.
Thank you very much. Any other questions, contributions? You can raise your hand or type in the chat.
And I'd like to say thank you for the impressive turnout as always. I'm very flattered that you take time out of your busy schedules to come and listen to me rant for an hour.
Thank you so much also for being willing to impart the knowledge to us.
Thank you. Okay, it seems I've answered all of your questions, so I will bid you good evening. The next presentation, I will be in touch as to the time and date. The topic will be preeclampsia and eclampsia in the context of the peripartum period and how to manage the stepwise approach, what drugs we use, and sort of the key differences in managing this patient as opposed to a normal epilepsy or liver dysfunction. Okay.
Well noted. Thank you all very much for participating in today's lecture, and have a good evening.
Thank you. God bless. Bye-bye.
Bye.